thinking about clinical trials and very targeted strategies. Dr. Azen is a professor in the Department of Neurosciences at UCSD, and he is also the director of the Alzheimer's Disease Cooperative Study, an NIH-funded consortium that carries out clinical trials in Alzheimer's disease.
Thanks, Doug. Good morning, everybody. Okay, so we're going to talk about therapeutics with a focus on prevention. And just to start with this slide, the history of Alzheimer's disease therapeutics started off in the 80s when people first approached this as a treatable disease. There was some success with the development of the cholinesterase inhibitors and memantine. And then since 2003, when memantine was approved, we've had a period with no advances in prescription treatments for Alzheimer's disease. So that has been the discouraging fact in therapeutic research in AD. So today's therapy, cholinesterase inhibitor, memantine, maybe something else like vitamin E, modest effects, modest benefits, but a long way from where we need to be. So our current therapies are helpful, but entirely inadequate for the treatment and certainly for the prevention of Alzheimer's disease. Now, in thinking about treatment versus prevention, I'm going to talk about this as we go through this. One of the notions, one of the explanations that many of us talk about for why, since 2003, we've had no successful drug development in Alzheimer's disease, one of the leading hypotheses is that our focus has been in AD dementia. AD dementia is a late stage in a long disease. This disease, as I'll show you, starts much earlier, and by the time that dementia is present, the disease is advanced, and the changes in the brain and in synaptic function are advanced. And it may simply be that as we have moved from the symptomatic therapies, the cholinesterase inhibitors and memantine, to efforts to modify the disease or prevent the disease, we've started much too late to see efficacy. So the dementia stage may be too late for disease-modifying therapies, and perhaps that's the reason we've had so little success. Now, disease modification and prevention may be two different things, or they may be the same thing, and I'll be talking a bit about that. People have described trials as prevention trials when they have aimed to slow the onset of dementia. But as I'll show you, the disease is really a gradually progressive one going on for many years before the onset of dementia, and I believe that it is more accurate to think of treatments that are started in people with mild cognitive impairment, for example, aiming to delay the onset of dementia. I believe this is more accurately described as pre-dementia treatment of disease. The disease is already present in mild cognitive impairment rather than true prevention. And indeed, regulatory agencies have indicated to those of us working on new therapies that nothing is ever going to be called a preventive treatment for Alzheimer's disease because it's impossible to prove prevention. And I think to some extent we have a semantic challenge here. Prevention of dementia, I would like to call treatment of early Alzheimer's disease. Prevention of symptoms, that is, moving from mild cognitive impairment to try to actually prevent the onset of symptoms leading to Alzheimer's dementia, that's been called secondary prevention. We often refer to it as secondary prevention, but I would describe that as early treatment as well, because even before the onset of symptoms, this disease is present in the brain. I think it's early treatment. Ultimately, I believe the goal will be primary prevention, and I'll come back to that at the end of my talk. But for the most part, trials that are underway now that are called prevention trials are really efforts to treat this disease much earlier than all of the dementia studies, treating either at the mild cognitive impairment stage or even the pre-symptomatic stage, but at stages in which changes in brain are already present, so that these are better called early treatment trials rather than prevention trials. Now, moving away from that semantic challenge, how do we find strategies that are actually going to change the course of this disease, whether administered in the mild symptomatic stage or in the pre-symptomatic stage? How are we going to find strategies that change the course, that do more than the mild symptomatic benefits of today's prescription treatments, and actually change the course of Alzheimer's disease? Well, you just heard from Dr. Yaffe that epidemiology suggests a bunch of possible interventions that need to be tested in trials. So one area we can look for ideas for strategies are epidemiological observational studies that might suggest exercise or cognitive stimulation or diet or attention to weight, lifestyle changes that might alter the risk or rate of progression of dementia. Another approach to prevention strategies might be to focus on those comorbid conditions that seem to play a big role in contributing to the symptoms, to the manifestations of Alzheimer's disease. For example, vascular disease and diabetes, and I think that makes sense as well. And of course, the two are not distinct. The epidemiologically driven strategies and the comorbidity-driven strategies often turn out to be the same, focusing on weight and exercise and cognition to reduce the risk of vascular disease and diabetes. But my major focus in this talk will be prevention strategies that are not derived from epidemiological studies and not targeting the comorbidities that contribute to the manifestations of Alzheimer's disease, but rather actually focus on the neurobiology of Alzheimer's disease, prevention strategies that are aiming to reduce the accumulation of the specific lesions of AD, the plaques and the tangles. My focus on that is not to devalue the epidemiological ideas. We need to do much more work, and we need to investigate all plausible strategies. And until we are successful in eliminating and preventing Alzheimer's disease, we need to do much more work. Many more studies are needed. So if we're going to focus for the moment, for this talk, on the neurobiology of the disease, we come to this picture, this cartoon that's describing the neurobiology of AD. So on the right, you have some normal cellular structures, a neuron, and then below a blown-up neuron with a membrane, and some proteins within the membrane, and some structures like microtubules that are necessary for the function of neurons, of brain cells, and mitochondria that are responsible for energy production within the cells. And then in the bubble on the left, you see all these things going wrong in Alzheimer's disease. And you have fragments of a normal transmembrane protein accumulating and clumping together to form amyloid plaques, and you have tangles which are derived from a protein called tau, which is located around those microtubules and becomes chemically changed and then aggregates into these rope-like densities within cells, and the mitochondria fail. All these things go wrong. This leads to many neurobiology-driven targets for disease modification and prevention for Alzheimer's therapeutics. And indeed, all of these processes have been targeted in the drug development arena. But many of us, and certainly I believe that of all the targets, amyloid has by far the strongest rationale. Rather than looking at changes to the mitochondria and the microtubules within the cell, we think those are downstream. Those are effects of the generation of amyloid. We think that amyloid the accumulation of amyloidogenic fragments. That means sticky fragments that are toxic to cells and clump together to deposit in the brain. We think that amyloidogenesis, the formation of brain amyloid and diffusible pieces of amyloid in the brain, is driving Alzheimer's disease. And if that's the case, then prevention and disease-modifying interventions should focus on the early changes. Remove the drivers, attack the amyloid, and then the downstream effects, the tangle formation, the synaptic failure, and the symptoms of dementia, they will improve as a result. The strongest rationale, and there is a wealth of evidence supporting this idea, that amyloid is a primary target for disease modification and prevention. The most compelling evidence comes from the genetics, in that every known genetic cause of Alzheimer's disease directly influences the accumulation of amyloid. All the causes of familial autosomal dominant AD are mutations in proteins that contribute to the generation of the amyloid peptide, either by increasing the expression of the precursor protein or actually influencing the clipping of the protein to release amyloidogenic fragments. And Down syndrome, everybody with Down syndrome develops Alzheimer's disease, and that's because the amyloid precursor protein, the protein that's cut to release amyloid, is on chromosome 21, and Down syndrome's trisomy 21. They have too much of the precursor, so they develop amyloid, and then they develop Alzheimer's disease. The genetic evidence strongly indicates that the driver of a very complex process is amyloid, and therefore disease modification efforts should not ignore the driver. And in fact, most studies have focused on amyloid. And that's led to studies that have attacked amyloid at multiple points. The generation of amyloid, the release of this toxic, sticky peptide from the amyloid precursor protein, APP. You can reduce that production of A-beta, that cleavage of APP to release A-beta, by inhibiting the two enzymes necessary for that step, and they are beta secretase and gamma secretase. So that gives rise to the secretase inhibitor approach to disease modification and prevention. You can attack the amyloidogenic fragment itself, A-beta, and you can do that with antibodies and vaccines and other approaches, so that you remove the toxic fragment from the brain. Or you can target the damage done by the amyloid, and that might be through anti-inflammatory drugs, because amyloid induces a destructive inflammation, or antioxidant drugs, because amyloid induces the generation of toxic free radicals, or by giving proteins that are known to protect neurons against amyloid, such as neurotrophins like nerve growth factor or BDNF. So all of these are strategies that target the primary driver of Alzheimer's disease, which is accumulation of amyloid in brain and amyloid-mediated damage in brain. But that's what we've been doing for 15 or 20 years without success. I'm going to give you a few examples of that absence of success. Semegacestat is an effective gamma secretase inhibitor developed by Lilly. Looked very promising. It looked promising because there were a bunch of studies, and I won't go through the graphs, but what they're showing you is that this is a drug that can be given by mouth, gets into the cerebrospinal fluid, gets into the brain, and was shown to actually reduce the generation of amyloid fragments in the cerebrospinal fluid in humans and in the brain in animals. So this was a rationally developed drug based on this amyloid hypothesis, the idea that amyloid is driving Alzheimer's disease, developed with strong evidence that it was effective in the central nervous system, a rational approach that gave us great optimism that it would work. And yet the phase 3 studies of semegacestat were entirely negative, despite the fact that this was a rational anti-amyloid approach. The studies, the randomized controlled trials of semegacestat as a disease-modifying therapy for Alzheimer's disease were entirely negative. The only effects seen were were adverse effects. How does that jibe with the amyloid hypothesis? Well, it comes back, I think, to what I said earlier, which is that here we're attacking the driver, the amyloid peptides, at the stage of dementia. Why at the stage of dementia? Because that's the definition of Alzheimer's disease. Its onset is the onset of dementia. And the regulatory path for drug development required a focus on dementia, but dementia is very late in the process. And I believe that the reason that semegacestat failed is because it was too late. Dementia is too late in the multi-year progression of Alzheimer's disease. That's the end stage. It's too late for attacking the generation of the amyloid peptide. There are still secretase drugs under development, other gamma secretase targeting drugs, and especially beta secretase targeting drugs. They need, in my opinion, to move at an earlier stage than dementia, and they are. And the gamma secretase and beta secretase studies, while some are still being done in dementia, they are starting to move to the pre-dementia populations, such as the mild cognitive impairment population, with the idea that you need to go early with these treatments. Now, probably the greatest effort in drug development aiming for disease modification and prevention has been actually using immunotherapy to target amyloid, because we know from the earliest studies in mice that were genetically altered so that they would accumulate amyloid in brain, studies showed that by vaccinating mice against amyloid, by injecting them with amyloid fragments, aggregated pieces of amyloid, they would develop antibodies against the amyloid, and those antibodies would clear the plaques. A remarkable therapy. That led to many, many efforts to develop immunotherapy as approach to Alzheimer's disease, immunotherapy targeting amyloid. It's a long story, and I won't tell you the whole story. It started with AN 1792 active vaccination, which seemed to remove the amyloid, but did not have any clinical benefits. It went through bapineuzumab, a monoclonal manufactured antibody that was infused. So rather than a vaccination, it was an infusion of an antibody that actually targeted amyloid and was shown to reduce amyloid in brain, but had no effect in phase 3 trials. All of the immunotherapy trials have been negative. The closest to a positive result is what I have on the screen now, which is with solanezumab, in which a study done by Lilly, the developer of solanezumab, was a negative study. It showed that there was no significant benefit in mild to moderate AD, but if you focused on the mildest subjects only, there was indeed a treatment effect with a slowing of cognitive decline in the milder subjects. It's a negative study. You have to live with the results based on your pre-specified trial design and analysis, but in secondary analyses, encouraging evidence that the mildest people seem to benefit. That's the closest to a positive study with anti-amyloid immunotherapy. And so then the third category of disease modification based on amyloid, after the secretase inhibitors and the immunotherapies targeting amyloid, is providing protective therapies. And this encompasses many approaches, as I said, including antioxidants and anti-inflammatories. And again, I will summarize a huge body of evidence by saying that, well, all the trials so far have failed. Some are still underway. Here at UCSD, Mark Dushinsky developed this nerve growth factor gene delivery approach that is now being tested in a phase 2, a randomized trial of a neurosurgical approach to deliver a protective gene, and we don't have those results yet. But all the studies that have been completed to date of interventions aiming to protect brain cells against amyloid have been negative. Everything has been negative. This is a partial list of the negative trials. The list is in fact very long and very discouraging. We are so confident about amyloid being the best target, but we have nothing to show for it. So, is this whole hypothesis wrong? Are we targeting the wrong thing? We've had all these trials and no successes, just a string of phase 2 and phase 3 disappointments. I don't think that that means we throw out the amyloid hypothesis. I continue to believe that the genetic support for this approach is highly compelling and in fact is correct, that the driver is amyloid and that the best approach to disease modification and especially prevention is going to be to disrupt this amyloid pathway. I think the reason we have failed is because we've intervened too late along the disease spectrum. We need to rethink the disease, and this has been going on just over the last 2 or 3 years in the field. We need to think of Alzheimer's disease not as Alzheimer's disease meaning dementia, where the diagnosis is made based on criteria for the presence of dementia. We need to define the disease much, much earlier. And we now know how to do that. And we do it using biomarkers, and you've been hearing about biomarkers today. We now can talk about a specific stage, a stage clearly tied to Alzheimer's disease that is much earlier, much milder than Alzheimer's dementia. And that's what we call prodromal AD. And prodromal AD is essentially mild cognitive impairment, cognitive symptoms milder than dementia, but tied to Alzheimer's disease through biomarkers like amyloid imaging in brain. It's a way of specifically, accurately identifying people who will develop Alzheimer's dementia because they already clearly have Alzheimer's, because they not only have cognitive impairment, but they have biomarker evidence showing that there is plaque and tangle formation in brain. So prodromal AD is an earlier stage and more appropriate than AD dementia for anti-amyloid treatment. And preclinical AD is also defined by biomarkers and allows us to identify people even before they have mild cognitive impairment, before there are any symptoms, just on the basis of specific biomarker evidence of Alzheimer's disease. So I just wanted to make clear the difference between mild cognitive impairment and prodromal AD. Mild cognitive impairment is a clinical syndrome that was described quite a few years ago by Ron Peterson in the first real effort to be able to identify people with Alzheimer's before the onset of dementia. And mild cognitive impairment has been very important to clinical practice, giving us a framework for talking about the symptoms and what they mean in people who are not demented. The problem with the concept of mild cognitive impairment is that it was not sufficiently specific. It includes earlier stages of other cognitive disorders like vascular disease in brain or Lewy body disease or frontotemporal dementia. So it was not specific to Alzheimer's spectrum disease. And therefore, the utility of mild cognitive impairment for clinical trials was problematic. When you enrolled individuals with MCI, you were enrolling individuals with many different disorders, early stages of many disorders, and trying to treat them with interventions that target Alzheimer's disease. So it is a messy, problematic trial design, and all of the MCI trials failed as well. But prodromal AD, that is taking mild cognitive impairment and further characterizing this clinical syndrome with biomarkers that are specific for Alzheimer's disease, like the presence of amyloid in brain by PET scanning or cerebrospinal fluid analysis, this gives us a much better population for pre-dementia study of anti-amyloid drugs trying to delay the onset of dementia or slow the progression of the symptoms. Ultimately, we're concerned that even prodromal AD is too late. So as we have spent an enormous effort over the last decade in characterizing the biomarkers that give us a window into the early brain changes of Alzheimer's disease, we find that the biomarker evidence indicates that Alzheimer's disease starts many, many years before a diagnosis even of MCI or prodromal AD. So again, if the amyloid hypothesis is right, we should be intervening against amyloid at the earliest possible stage before it's too late. And that may not be at prodromal AD. That may be at what we now call preclinical AD, which means no symptoms whatsoever. People who are entirely clinically normal except for biomarker evidence that the brain is showing the changes of Alzheimer's disease, the accumulation of plaques and tangles. This is a paper that was published a few years ago by Chris Rowe in Australia, summarizing lots of evidence from pathology studies and from amyloid PET imaging studies that clearly show that plaques are deposited in brain 15 years before the onset of clinical Alzheimer's disease, 15 years before. So there are about 5 years of mild cognitive impairment and 10 years of no symptoms whatsoever preceding the onset of Alzheimer's disease dementia, 15 years. If we want to prevent this disease, prevent the dementia, slow the progression of the symptoms of Alzheimer's disease with an anti-amyloid drug, we need to start many years, not just prodromal AD, but many years before AD dementia, and that means preclinical AD or even earlier. And this is just a summary of lots of biomarker evidence showing that many things become abnormal many years before even the earliest stage of mild cognitive impairment. And we think that among the earliest changes are the CSF and amyloid PET imaging evidence of amyloid accumulation, which is, of course, highly consistent with the idea that that's the driver. So those red and blue curves captured in that circle, in that oval, in the stage that we call asymptomatic or preclinical Alzheimer's disease, the marked changes at that phase are the indicators that amyloid is starting to accumulate. CSF A-beta is going down, and amyloid PET imaging is showing the accumulation of amyloid in brain. That gives us the mechanism for accurately identifying individuals at this very early preclinical stage of AD. And notice that some of those other curves that relate to brain volumes and even cognitive function also become abnormal even before there's any clinical syndrome, even before EMCI, early MCI. There are changes in cognition and brain volumes. That gives us a way of assessing the impact of very early anti-amyloid intervention. When we first started to think about doing trials in this preclinical AD population, this very early population, we started to study what characterizes preclinical AD. What are the changes that we might see in people who have amyloid in brain but absolutely no symptoms? And the way we did this was to look at the largest biomarker study, which is ADNI, the Alzheimer's Disease Neuroimaging Initiative. ADNI includes a control group. These are people who are entirely normal, who are enrolled in the study as a reference group for the mild cognitive impairment and dementia study groups. So this was a normal control population as a reference point. When we started to look for amyloid, because amyloid imaging became available and CSF measurement of A-beta became standardized, we found that 1/3 of this normal cohort had evidence of amyloid in brain. So the entire cohort was clinically normal. 2/3 of them had no evidence of amyloid, and 1/3 had evidence of amyloid. And we now think that that 1/3 of the normals, 1/3 of everybody over the age of 65, has amyloid. We think this is the earliest stage of Alzheimer's disease. And we started to investigate the differences between normals with amyloid and normals without amyloid. And what I show you here is that brain atrophy, here as measured by enlargement of the ventricles, the fluid-filled cavities in the brain atrophy is an unavoidable aspect of aging, but in people who have amyloid, it goes twice as fast as people who don't have amyloid. It's a measure of amyloid-mediated damage years before the onset of symptoms, accelerated brain atrophy. What we were most surprised to find is that there's a cognitive signature as well. These are people who are entirely normal, they volunteered as normals, and yet if we track their cognitive performance, we also see that cognitive decline is happening below their radar, below their perception and below the perception of their physicians. There's cognitive decline. So not only is the amyloid in these normals accelerating brain atrophy, it's actually has effects that we can measure by cognitive performance tests, memory tests. And this was a surprising and I think very important finding that came out of studying the normal control group in biomarker studies. And when we looked at data from other large cohort studies that followed people who eventually developed dementia, but by design they started to follow normal midlife populations, people for many years, hoping to understand the earliest changes before the onset of dementia, we found confirming evidence that even many years before any symptoms, you could measure cognitive decline that would eventually lead to dementia. So we found confirmation in independent prospective cohort studies that cognitive impairment, accelerated decline on cognitive performance tests precedes the onset of dementia by 15 years. And this is just a slide from a study of autosomal dominant Alzheimer's disease put together by Randy Bateman that also showed that there are biomarker but also cognitive evidence of the disease 15 years before the onset of the syndrome of Alzheimer's disease. So many different studies providing support to the idea that cognitive decline occurs, that is, performance changes on cognitive tests occur many years before the onset of symptoms. Now, again, there are two ways that we can identify people at this asymptomatic stage, many years before even the onset of mild cognitive impairment. And the two primary ways are by measuring A-beta fragments in the cerebrospinal fluid, and more recently by doing amyloid PET scans, scans like Amyvid, and now there are actually 3 different amyloid PET scans available clinically. This is just showing what amyloid PET scans look like, and the fact that you can use them not only to identify the accumulation of amyloid in people with Alzheimer's disease or MCI, but also in the normal older population where 1/3 have positive amyloid PET scans. But in this slide, we're showing that, in addition, targeting amyloid reduces the signal. In other words, anti-amyloid interventions can be studied by their effect on the amyloid PET scans, that the amyloid PET signal of amyloid plaque load will actually change in response to anti-amyloid intervention. The advent of amyloid PET imaging is a huge change. It gives us a tool that is reliable and has been proven to correlate with plaque load at autopsy, a reliable, clinically acceptable tool, safe tool for the study of amyloid in brain in asymptomatic or symptomatic older individuals. It's changed clinical practice, and it has, to a very major extent, changed clinical trial design, the ability to measure amyloid plaques in living people. So again, that's allowed us to do now in multiple studies PET scanning of the normal older population, and all of the results are consistent, showing that roughly 1/3 of people over the age of 65 who have no symptoms have amyloid in brain, and we believe that these people are at the preclinical stage of Alzheimer's disease. And so that comes to what our current notion of the earliest possible intervention against amyloid, I should say the earliest feasible intervention against amyloid, which we call a secondary prevention trial, trying to prevent the onset of symptoms, not the onset of dementia, but the earliest recognizable symptoms, to prevent the onset of those symptoms by identifying people with preclinical asymptomatic Alzheimer's disease and intervening at that point with something that attacks the amyloid. That's the secondary prevention with anti-amyloid intervention at the asymptomatic stage. And what should the outcome measure? How do we measure success? Well, we think the way to do that is to aim to slow that change in cognitive performance on memory testing in these asymptomatic individuals. In other words, since they're all normal, we can't judge the efficacy of treatment by following them for 15 years, just too long to be feasible. But we know that their cognitive performance declines without their appreciation of the change. So we use the cognitive performance decline to assess the benefit of the treatment. It's using cognitive performance as the primary outcome in a trial in asymptomatic individuals. So here's the trial that we've just launched here at UCSD and nationwide, and actually internationally extending into Canada and Australia, the A4 trial. That stands for Anti-Amyloid Treatment in Asymptomatic AD. This is a secondary prevention trial, preventing the onset of symptoms, but actually I would call it a very early treatment trial of AD neurobiology. For this trial, what we do is we screen people who are clinically normal, no symptoms. We scan them for the presence of amyloid. And those that have amyloid, we have a process for discussing what those results do or do not mean, and then offering them randomization into the trial, where there will be two groups, one treated with an anti-amyloid intervention, one treated with an identical placebo for 3 years, tracking cognitive performance change. And then at the end of 3 years, everybody gets the active treatment, the placebo group and the active group, so that everybody with brain amyloid will ultimately get an anti-amyloid intervention. Which anti-amyloid intervention? Well, recall that the closest we've come to positive results was in the mildest subjects in that solanezumab trial. Solanezumab, again, is a monoclonal antibody against the amyloid peptide. So we've decided to use solanezumab at this preclinical stage using this A4 trial design, screening normals for the presence of amyloid. Those that have amyloid are invited to enroll in a 3-year randomized controlled trial, with the primary outcome measure not being symptoms, because it will take too long to see the emergence of symptoms, but cognitive performance. And we've developed a sensitive test of cognitive performance in this preclinical AD population. We're also doing many other studies to fully understand how this treatment influences the brain, including serial amyloid PET scans, hoping to see the removal of amyloid, even amyloid tau scans, tau PET scans looking at tangles in the brain, cerebrospinal fluid studies, many different cognitive and clinical assessments to really understand the impact of intervening against amyloid at this asymptomatic stage. Just putting it in a different graphical way, we know that everybody, so if the downward sloping of all those curves is showing cognitive performance decline with aging, people who don't have amyloid have some decline with aging. Everybody does. That's the trouble finding names and slowed reaction times and constricted working memory that every one of us over the age of 40 has noticed. That's the blue line on top. But older people who have amyloid have a cognitive decline that's much faster, and that's the red line. And the A4 trial is capturing the presence of amyloid before there are any symptoms and trying to move the shape of the cognitive curve up towards the amyloid negatives by attacking amyloid. We're very excited about the trial design. We think that having cognition as an outcome measure as opposed to a biochemical indicator of amyloid provides a face-valid outcome. We know that the primary symptoms are cognitive, and so measuring cognition even before symptoms are present makes sense. And if we can have a favorable impact on cognition, even a subclinical change, an imperceptible change in cognitive performance, if we can show a statistically significant slowing of cognitive performance decline with an anti-amyloid intervention, we will have strong evidence that there will eventually be clinical benefit to anti-amyloid treatment in this preclinical asymptomatic population. And we're very pleased that regulators here and in Europe have completely accepted this design, and if the study is positive, this will be a path towards approval of anti-amyloid treatment targeting this early asymptomatic stage. I'm running out of time. I'll just show you the outcome measure here, which takes advantage of the MMSE, where we saw the first evidence of cognitive decline in this normal population. We've added some additional tests that seem to be very sensitive to amyloid-mediated cognitive decline. We've done studies looking at many cohorts internationally, and they all show that amyloid is associated with accelerated decline on this cognitive composite. And we have launched this very complicated and ambitious study that will involve screening thousands of people, doing PET scans on thousands of people to identify 1,000 amyloid-positive, clinically normal people to randomize into active treatment or placebo for 3 years, after which the placebo group also gets active treatment. We're also going to longitudinally follow the amyloid negatives. That is, in addition to screen failing them for the randomized trial, we'll keep track of them and do the same longitudinal assessments to further characterize the impact of amyloid positivity in a normal older population. And just recently, and this is really in the past year, tau imaging has become an exciting new tool that we've just incorporated into the A4 design. We're now able to image not only plaques but tangles in brain, and so we hope to see a reduction not only in amyloid in brain and a reduction in the rate of cognitive performance change, but also a reduction in the accumulation of tangles with treatment in A4. So we're including tau PET imaging as well. Now, we've selected solanezumab for the first study for A4, but we view A4 as a new paradigm for AD secondary prevention, disease-slowing interventions. We hope to add not only immunotherapy, but add secretase inhibition, especially with the beta secretase inhibitor, and eventually combination anti-amyloid therapy to this trial design paradigm to get our best chance at secondary prevention of AD. There are other efforts as well, and just in my remaining few seconds, some of the other efforts to bring anti-amyloid interventions very early to AD involve the genetically determined populations. So the Alzheimer's Prevention Initiative in PS1 carriers in Colombia. The DIAN study, Dominantly Inherited Alzheimer's Network, is starting anti-amyloid trials in PS1 mutation carriers in the US and in Europe. And there's a growing effort to study and intervene with anti-amyloid treatment for the Down syndrome population, led by Mike Yaffe here at UCSD. Ultimately, and I said, A4 is really secondary prevention, targeting amyloid after it's accumulated, but before there are symptoms. Ultimately, we're going to want to monitor for amyloid abnormalities even before a PET scan becomes positive, just as we monitor cholesterol before someone has angina or heart attack. and we're still working on better tools for studying amyloid dysregulation in middle age. We need more understanding of these pre-amyloid PET positive populations, these middle age or young old age individuals. We want to target amyloid dysregulation before the PET scans are positive, and that will eventually lead to primary prevention of Alzheimer's disease. I've talked about amyloid. We don't have any proof that any of this is correct, and until we have succeeded, we need to be open to other possibilities. And so I didn't want to leave you without talking about efforts here and around the world on tau targeting strategies, including tau immunotherapy. You heard from Dr. Yaffe about insulin targeting the glucose dysregulation, nerve growth factor and BDNF neurotrophin interventions, and many others, and we need to, as vigorously and broadly as possible, pursue all of these plausible strategies because, of course, Alzheimer's disease is among the most important healthcare issues worldwide. So just in conclusion, I think we've moved from the idea that Alzheimer's disease starts with dementia. Now we consider it to be a very slowly, gradually progressive disorder over 20 years or longer, and that if we're going to target amyloid for disease modification, we should move as early as possible. We've already launched this A4 secondary prevention trial, and we're already thinking about primary prevention, and I believe that's really cause for optimism in the field for getting beyond this 10-year of failures in phase 3 trials and actually bringing to clinic effective prevention against Alzheimer's disease. So I'll stop there. Thank you very much.